your speaker for today's session. A very warm welcome to all of you joining us today. I'm truly delighted to be your moderator for this insightful webinar presented by Neuroptech. Today's session is centered around a very important topic in the field of eye care, which is amblyopia, myths and facts, a behavioral concept. This discussion promises to deepen our understanding of amblyopia, clear misconceptions, and explore its behavioral aspects. We're honored to have with us Dr. Navneet Sharma, a distinguished expert in the field of optometry and allied health sciences. Dr. Sharma is currently serving as the head of Department of Optometry and Allied Health Sciences at CGC University, Mohali. His vast experience and dedication to education and clinical excellence make him the perfect speaker to guide us through this topic. But before we begin, just a few quick points for everyone. Kindly keep your microphone on mute throughout this session to avoid any disturbance. If you have any questions, please drop them in the chat box. We'll be taking them up during the Q&A session at the end of the session. Please stay with us till the end of the session for some important announcements and for certificate announcements. Now, without further delay, let us get started. It is my privilege to invite Dr. Navneet Sharma to take over the session and enlighten us with his talk on amblyopia, myths and facts, a behavioral concept. Sir, the virtual stage is all yours.
पहले वो document खोल लो था. Thank you very much. First of all, I would like to thanks the Neuroptech for inviting me for these sessions. So, although my topic is the topic is basically a different topic, so I'll try to basically keep the most important aspects of amblyopia. But I always believe that this topic should be in basically in an offline mode rather than online mode. But still, I'll try my best to involve all the aspects. And just wait a minute. Talk about behavior definitions. So earlier we have a functional definition. Now we discuss about the behavioral definitions. So behavioral definition says that the behavior definition is a neurological definitions instead of one that is only ocular. So it is basically based on the neurologically problem in the eye. So behavior means it is related to the brain, not only with the ocular. So amblyopia is a neurological conditions which affects the optimal functioning or binocularity and many other visual abilities that is needed for optimal visual functions. So if the both the eye is not basically function properly, so that can lead to amblyopia. So that means the brain is not able to basically make both the eyes work together. So that can lead to amblyopia. So it is more neurologically part rather than a basically eye part. So amblyopia is a problem primarily of binocular competitions. So this picture says so many things. If we have two people, two persons, one is stronger, other one is weaker, or you can say that one is more dominant than the others because of any reasons. So that can basically lead to a competition. So as far as the eyes is concerned, that is a binocular competition between both the eyes. Maybe one eye try to dominate the other eye. So like we take an examples of this, like binocular competition, it is a normal basically process with each eye taking turns speaking to the mothers. So if we have two kids, so each of the kids try to speak to the mothers. They try to basically take attentions of mothers. So maybe there will be a rivalry between both the eyes. So, but the competition can become more abnormal as one eye or one child become totally dominant to the others and actively suppressing the other child, thus preventing it from speaking to the mother. So one child basically tried to dominate the other eye, like this. Basically, child is more basically dominant than this child. So this is a continuous process. So the dominance and active suppression increases, like this child basically dominating this, and it is a continuous process. And Then the stage comes the dominance and active suppression increasing until the eye or a child no longer makes to effort to speak to the mother. So then this happens. So we can correlate this child to an amblyoptic eye. Like it start from here, and it is a continuous process because competition is a common, it's a continuous process which happens in the life. Then it again and again, then it result into this, and this is basically a result that we can say that a amblyoptic, and this is the suppression. So the amblyoptic eye is not a weak eye basically. So suppression is an active eye, the other eye basically try to dominate. So if we say that these two basically peoples, one is more stronger than, we can't say that this is a weaker, but this is more stronger than this person, and this definitely you can say that suppressed this person's, and as this is a continuous process, so it can lead to a permanent basically, you can say that deactivate these persons, and that result in a amblyopia. So amblyopia is a result of a suppression of one eye to the other eye, and it is a continuous process, and that suppression at the end lead to the basically amblyopia. So brain is basically ignore that eye which is a suppressed eye. So definitely suppression is beneficial to a person. It is also a protective survival. So like this person's cannot, this boy cannot basically fight with this guy. So what will happen? This definitely will go in a survival way. So survival mechanism will activate in that boy, or in when we talk about eye, it is a kind of a survival mechanisms, so that that eye is not basically tried to basically counter that domination of the other eye, and that basically condition lead to a amblyopia. So amblyopia is basically not a disorder, it is not a disease, it's a process. That process happens because of the suppression or suppression of one eye which is more dominant than the other eye. So what happens, the brain is basically shut down the weaker eye. So it's a continuous process, and that can lead to an amblyopia. So amblyopia is definitely not in the eye, it is in the brain. So it is not basically the eye is a problematic eye. The brain is basically not able to, or not basically you can that stop using the eye which is a weaker or either dominant eye. So amblyopia is a binocular problem which is manifested monocular. So amblyopia is not an you can say that it's a one eye problem. It's a binocular problem which basically result or manifested monocularly in one eye. So it is not an eye with amblyopia, it's a child with amblyopia, or it's a person with amblyopia. So we can't say that a person's have an amblyopic eye. So amblyopia is not a disease or disorder. So as a behavioral, you can say the definitions concerns. So a person can become amblyopic. So amblyopia is not just a problem with reduced visual acuity. We always say that it is a reduced visual acuity, which if one eye is around 20 by 20, other eye is 20/40 or 20/60. So we say that this amblyopia. It is not just a visual acuity. There are multiple things which also involves, like deficient eye movements. There will be a problem in the fixation skills. Unsteady and eccentric fixation will be there. There will be a decrease in the saccades and pursuit accuracy. So saccades basically is a fast quick movements, and pursuit is a basically slow movements. There is a problem in the accommodative skills, decrease amplitude, accuracy, and sustaining ability of the accommodation, and definitely increase the accommodative latency. So these problems also affected. Poor form of discrimination due to decreased contrast sensitivity, and these patients definitely have a contrast, reduced contrast sensitivity as well. There is will be a special uncertainty as far as the when the person is see the basically in the vast space. So increase counter interactions, there will be a crowding phenomena, and definitely there will be a reduce in the visual information process speed and its ability. So what are the treatment? I want to use this word treatment. We always use this word, which is management. So treatment is a part of management. Management is a whole process actually. So as far as a treatment or management is concerned, so there is no single management or treatment plan. There are multiple things as an optometrist or as an eye care practitioner we have to do as far as these children are concerned. So, amblyopia treatment options as far as the ophthalmology and optometry is concerned. So, when we talk about ophthalmology, it will be a total occlusions or maybe full optical prescriptions. So, this is an ophthalmological kind of management of amblyopia. And in today's clinical practice, most of the practice normally we do like this way. We give full occlusion to a non-amblyopic eye, and we also give a full optical prescription to the patient. So this is the first line of management, and most of the these kind of management is basically happening as far as the amblyopia is concerned. So when we talk about optometric management, so optometric management may be lenses, maybe no occlusion or partial occlusion plus vision therapy. So this is an optometric optometric management options. It could be lenses, I won't say no occlusions or maybe only partial occlusions. So, and plus vision therapy, which is very, very important. So classical treatments like we do the patching. So there are multiple types of patchings are there, and we always give full correction to the eye. This is a full power optical prescriptions. So these are the patchings. So, classical lens prescription consists of optimal refractive corrections based on maximum plus, and by using the cycloplegic refractions, full correction of anisometropia, or even in astigmatism also. The goal is to provide maximum visual acuity initially, but what seems to be optimum normally is not the best. We always think that always give full corrections to the patient that can improve the visibility, but it is not like that way, but we think that. So classical management, the weak link is classical treatment full-time occlusion full optical correction is that it completely ignore the neuroscience research and treat amblyopia as a monocular problems instead of a binocular problems. Already I told you that we have discussed that amblyopia is not just a basically a one eye problem. It's a problem of a binocular eye which basically manifested in monocularly. So in amblyopic management, we have to work with both the eyes rather than not only focus in one eye. So the behavior management key concepts are concerned. So we are working on the brain but not the eyes. We have to work on the brain, how brain basically uses both the eyes simultaneously. It is not just only about to improve the visual acuity. So we are in the new era of neuroplasticity. We It is a new concept. So what is neuroplasticity? So we are in the new era of neuroscience, and every day more applications are being investigated for brain rehabilitations. So, neuroplasticity is a reality that nobody now denies. So, V.S. Ramchandran, a very renowned author, basically, who have written very precisely about neuroplasticity. So, what is neuroplasticity? So, it is a brain's ability to change, adapt, and recognize its structural and functional throughout the life. So throughout the life, neuroplasticity will happen. So this process or this procedure allows the brain to form new neural connections in response to learning and experience, or even in case of injury, and it is fundamental for learning, memory, and recovery. It means that brain is basically not fixed after childhood, but can continuously revive itself by strengthening existing pathway and creating new ones. So it's a continuous process. We can't say that if one part, because uh, the as far as the image is forms, whatever we are seeing, it is basically happening in the brain, not in the eyes. Eyes are just windows, and it is because of the neurons correct connection with each others we are able to see the world. So neuroplasticity, because in amblyopia, definitely the neurons who are responsible for the visual acuity or vision formations, they might be affected, but it can be basically overtaken by the neuroplasticity or the new neurons. Basically, we start doing the connections with other neurons. It's a continuous process. It is not like that if it is die, then it will not basically restore it. So key concept: neuroplasticity and neurogenesis that exist normally throughout the life, right from the beginning of a younger age until the older age, till our death. It's a continuous process. So it is a process by which neurons can increase their connection with other neurons through the sensory stimulations, learning, and experience. So science basis for the optometric vision training. So some research says that the effectiveness of stimulation has been demonstrated and replicated in a wide variety of studies. In fact, it is known that regular activity and systemic activities and enriched environment stimulations the growth of new nerve connections, mainly throughout the life. So I always said neuroplasticity is a process which happen throughout the life. If we do some basically activity, those are affected. So that result in that the person is able to do that activities or improve that activity thoroughly by doing it regularly or in a enriched environment. So more concept are concerns. So as far as the amblyopia is concerned, so as far as the neuroplasticity is concerned, the cells basically that have not been destroyed, they are just sleeping and ready to awaken. So it is not key, this is dead. No, these are destroyed. They are just sleeping and it is ready to awaken. So the cell sleeping and ready to awaken, and how will they be awakened? How we basically make an effort to awaken those cells. So the management option is concerned, we have to do the find the key and the right key. Finding the right key is very important as far as the behavior management is concerned. So the behavior optometric management protocol are basically based on big three keys to success as far as the amblyopia is concerned: behavior lens prescriptions, behavior use of occlusions, behavior optometric vision therapy. It could be monocular first, then monocular fixation in binocular field, then binocularly. So behavior lens prescribing based on neuroscience, based on the distance and near point retinoscopy, subjective fractions, perform test in a monocular in a binocular field situation. So we use the do the test in a monocular eye, but in the binocular field conditions, under compensate until fixation is steady and centering. Refractive compensation based upon minimum compensation to achieve maximum binocular result. So our basically focus is not basically on make both the eye visual acuity basically equal. Our main goal is to make both the eye binocularly on the same page. So behavior lens prescription based on the neuroscience goal of the prescription to reduce the binocular competition between both the eyes and improve the binocularity. It is not all about the improve or the visual acuity. It is basically improve the binocularity or reduce the binocular competition between both the eyes. So which eye to patch? This is a question always we do that. There is two types of patching. First one is the direct patching, other one is the indirect patching. So normally we do the direct patching in patch on the non-amblyopic eye. So allow the stimulus of an amblyopic eye. It reduces the competition and basically inhibit the inhibition from non-amblyoptic. It forces a non-amblyoptic, force the amblyoptic eye to work. So this is a direct patching. But how much basically, how much are we basically need a patch? Sometimes say that full patching is basically always recommended, but I don't think so. This is a right way of giving the direct patching. So I think 2 to 3 hours a day patching is very it's as effective as the whole day patching is concerned. So the purpose of having a patch is that the patient with an amblyoptic eye, if we are occluding the non-amblyoptic eye, the child or patient must do the near task as much as he or she can. Another one is indirect patching. So, patch the amblyoptic eye. Use with steady incentric fixation when direct occlusion and vision therapy are not showing any improvement in the visual acuity. So, normally, this is not commonly we do indirect patching, but in some cases we need to give the indirect patching to basically the purpose of having this kind of patching is to stimulate the amblyoptic eye by forcing it to work. So to disturb the suppression and to improve the incentric fixations, and the blockage of the amblyoptic eye retains the patient fixation. So once the eye is basically able to fixate centrally, then we can go with the direct patching as well. So occlusion materials, so total occlusion, we normally use these kind of occluders like form vision totally eliminated adhesive bandage type we use. Pirate patch, normally pirate patch is like that, which used by the pirates. Uh, Clip-on occluder on the glasses and opaque contact lenses, which is also we can basically do because in normally do these kind of parrot patching and bandage type of patching, it doesn't cosmetically look good. So we can use contact lenses, opaque contact lenses as well for these kind of patching. But the other thing is that normally what we do one when we block one eye, definitely we also even we block the better eye, we also basically disturb the binocularity also. So we can use basically filter glasses as well. So vision is not naturally degraded, blurred retinal imaging, but the retinal image still formed or still present. So we can use occlusion foil papers, filter testing bars, form the non-amblyoptic. Normally, as far as the behavior management of the eye is concerned, we normally don't recommend the eye to fully occlude. We can use basically a filters, and we can fog the non-amblyoptic eye to the level that amblyoptic eye usually 2 3 lines lower the visual acuity. So basically we reduce the visual acuity 2 3 line below the visual acuity of a amblyoptic eye, so that still the non-amblyoptic eye also basically the retinal imaging formation will still there. Basically that will not basically hamper the binocularity of the eyes. But when we occlude one eye, definitely it hampers although it forces the amblyoptic eye to work, but it also basically affect the binocularity. So normally in today's scenario, we recommend not total occlusion, we recommend a fog kind of a basically occlusion. So there is very various types of active vision therapies which we normally recommend in amblyoptic management. So I would like to add one thing is that uh, vision therapy is not an exercise. We always use this word. These are on ophthalmology always use this word. Vision therapy is an exercise. It is an orthoptics. It is an orthoptics. It's a continuation of orthoptics. No, vision therapy is not an exercise. It's a process by which we basically train the brain. It's not an exercise. We can say that orthoptics is an exercise which basically works on the extraocular muscles. But vision therapy is not an exercise. It's a training. It's a training of to the brain. So active neurooptometric vision therapy, the purpose of amblyopia therapy is to maximize the patient's performance in visual related tasks such as academic, driving, sports. Successful management can be accomplished and a long-term cure sustained if the emphasis is on developing the higher degree of binocular functions. Again, I would like to use this word. Our main basically goal is to restore the binocular vision, binocular functions. Our goal is not basically just more based on the improvement of the visual acuity. If a patient with a 20 by 20 or 6 by 6 visual acuity doesn't mean that that patient is binocularly basically normal. It is not basically you can say that it is false. It is not true. So the conventional approach of occlusion and full optical correction is rarely, if ever, needed. So when we talk about vision therapy, so normally in vision therapy we don't need these kind of conventional approach of occluding one eye. So vision therapy procedures which normally changing neural connections in the brain. So by doing the vision therapy or by using those procedures in the vision therapy, which what we do, we basically change the neural connections within the brain. So these are the various therapies, basically aspects of the therapies. First is the monocular, building confidence and self-esteem. Next one is monocular fixation in binocular field. That is just like an engagement. If there is an basically marriage is concerned, then binocular. The binocular means the marriage, the end result. First we work on monocularly, then we work on monocular eye in a binocular field in a binocular way, and the next step is the use of both the eyes. So first, active vision therapy, behavior optometric vision therapy like monocular. So what is the purpose of start the therapy? Monocular is restoring and building the visual ability of a eye which is supposed to be a weaker eye, which is supposed to be a dominant eye by the fellow eye. So restoring and building confidence and self-esteem in that eye. So that is the purpose of start vision therapy monocularly. So this is the first step as far as the amblyopia management is concerned. And it also established the central fixation. Then the other step will be the basically you can use macular integrated tester MIT test, basically like Hedinger brushes. They act as a foveal. These are the types of, I'm not going to go in detail with these kind of therapy because this is beyond this topic, and it definitely give by feedback to the patient about where the fovea is pointing. So this is basically a monocular kind of a test. So the next step is that monocular fixation in a binocular field. It's like a engagement. We are doing a engagement. Okay, it's a middle way. Then we also basically work on a one eye basically, but in the binocular field, in the binocular scenario. So monocular fixation, it is like the engagement. So these techniques allow both the eye to see peripheral objects while only the amblyopic eye sees the central details. So although both the eye sees the peripheral areas, but the amblyopic eye, which is basically the supposed to be a weaker eye, that normally see the central detail. So the results in addition, it basically help in improving the visual acuity. So it increasing the possibility that acuity gains will be maintained. So basically you can say that it's a kind of a vision therapy which normally act as a bridge to from monocular to binocular activities, improving the efficiency of the patients to use both accommodation and binocular system. So definitely it improves the visual acuity of the patient. So these are the basically various tests. So a unified peripheral field is normally presenting in both the eye, and the central, which is highly detailed, is normally only sees by the eye which is suppressed. So these are the various. Oh, I will not go in detail with these tests. Now the last one is binocular or the final end result or marriage. So this is the our basically goal. So the glue for this kind of marriage is binocularity, means the brain is able to see or able to work both the eyes simultaneously. There will be a sensory fusion and stereopsis maintained to gain the which will be gained from the vision therapy. So the fusion as well as stereopsis, this will be our basically main core part as far as the management of the amblyopia is concerned. So stereopsis means seeing solidly. Stereopsis is not just, as we always say, that a test of depth perception. No, it is beyond that. It's a very sensitive basically aspect into the quality of binocular vision. Any kind of binocular dysfunctions result in a affected stereopsis or stereo vision. So stereopsis is the single best indicator of overall function of both the sensory and motor portion of the visual system. So stereopsis is very, very important. So as far as the summary and conclusion is concerned, so don't forget to treat the whole child or adult. You are not treating amblyopia, you are treating a person with amblyopia. So we have to basically focus on this point. We are not just treating the or managing the eye with an amblyopia, but we are managing the person with an amblyopia. So an amblyopic patient might have so many other difficulty also, and we have to work on them. And we also need to work on any problem in learning motor bilateral integrations, perceptions, like. So classical treatment of amblyopia is just treat the eye. Classical treatment is not just based on new neuroscience research. So improved visual acuity is attainable for the majority of employees. When one compares vision therapy with the ophthalmological management or even the optometric management, normally we do in the clinical practice for amblyopia, there is one logical choice for treatment. So vision therapy is basically very, very impactful as far as the amblyopic management is concerned. So it provides much greater chance of success without resultant performance deficit or psychological issue of the patient. So it can improve performance and quality of life in a patient with amblyopia, which cannot be when optical visibility not achieved. So this is the conclusion. So we have to decide which one is a right way or a wrong way. So behavior optometric basically do the vision therapy to change the brain. So behavior optometric vision therapy treat people not just eyes, it changes the lives. Thanks. So one thing I would like to add, a person with a 6 by 6 vision doesn't mean that always feel that always if you are doing any kind of a clinical practice. So please don't think that a patient with a 6 by 6 or 20 by 20 visual acuity are normal patients, right? So this is just a visual acuity. We always basically conclude that a patient is reading the last line of the visual acuity chart. That means patient is normal. So that is not a vision. Vision is basically more than visual acuity. The chart normally which we use for distance and near, that only basically measure the visual acuity. But visual acuity is not vision. Vision is more than visual acuity, right? So as far as the binocular vision is concerned, so the vision is basically affected. A patient with a 6 by 6 visual acuity doesn't mean that that patient is normal. That patient might have any kind of a binocular dysfunction, right? And in other way, if a patient with one eye visual acuity is 6 by 6 and even other eye is 6 by 6 partial without any pathological changes, so that might also comes in the basically and that patient might be an amblyopic eye. Amblyopic eye doesn't mean that if there is a some of the books say that if there is a difference between the two lines both the eyes as far as the visual acuity is concerned is amblyopia. No, might be a patient with 6 by 6 or 20 by 20 in one eye and 20 by 20 partial or 6 by 6 partial in another eye. Might be that is not a significant amblyopia, but that is also comes under the category of amblyopia, although it is not basically significant or might not have any symptoms, or but still the patient in that patient the binocular vision is affected. So this is all about from my side. So I'm open to any questions if anybody
Thank you
from the
so much,
audience.
Dr. Sharma, for the truly insightful session. The way you explained each concept and addressed the common myths so clearly was absolutely brilliant. You didn't just share knowledge, you made us rethink how we look at amblyopia. Genuinely grateful for the clarity and depth you brought to this topic today. I'm sure our audience have gained a lot of and fresh perspectives on the behavioral concepts surrounding amblyopia. Now we'll move on to the Q&A session. If attendees, if you haven't already written the questions, please type your questions in the chat box and I'll happy to take them one by one.
Ma'am, I have a question.
Please write it
Yes.
down. Please write it down. Everyone, please write your
I
questions.
don't know. Ma'am, I'm not able to do it here. When we can, I'll do it now. Probably I have to move out also. That's why I'm slightly my question will might come a bit late. So I'm asking if it is possible to answer straight away, sir.
Okay, fine. Okay, all right, all right.
Thank you very much, sir. Thank you very much for a wonderful presentation, sir. I have two
Thank you.
queries. Sir,
Yes.
sorry, I'm Sanjay Mehta. I'm an optometrist
Okay.
from Chennai. Sir, two
Okay.
questions for me. Sir, of late, patching not been has been slightly, probably almost most of the specialists are not recommending patching. That is number one question for you, sir. And why is
Yes.
it so? And second thing, sir, what about red light therapy, which is increasingly gaining popularity in Western countries? In India, probably only two places I'm seeing it. But I want your input on both these things, sir. Thank you very much.
Your first question is kindly again repeat your first question.
Sir, sir, patching is increasingly not recommended for amblyopia therapy, sir.
Okay. 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 Okay.
By
Okay.
most of
Uh,
yeah.
you are saying that now the patching is not recommended basically.
Yes, sir. Yes,
Okay.
sir. Patching is increasingly not recommended
Not
for
recommended.
amblyopia therapy.
Okay.
Yes,
Okay.
sir.
Definitely when we do it's not that doing a patching is a bad thing, but actually the why we don't recommend patching these days, because definitely if we patch one eye, either the normal eye or the abnormal eye, it definitely also impact
Yeah.
basically impact your binocular vision na?
Yes, yes,
So
yes, sir.
basically, our work is that we work on the eye. We work
Right.
on both the eyes. We not work only one eye. So patching is just we are just if one suppose one child is dominant, other child is weak. We are basically eliminating the dominant eye, but we not don't make the both the eye. We don't make that weaker eye, which is supposed to be weaker eye, to be in competition with the dominant
Yes,
eye. So
yes,
patching
yes,
is
sir.
normally not recommended these days, but you
Yes.
can't say that patching is not recommended. You can use a patching, you can use partial patching, and you can use filters also, so that even the
Right.
under the patch also basically some sort of binocular vision is basically
Okay,
happens.
sir.
So this is the
Okay.
reason. And another question is that another question is
Red
that
light therapy, sir.
so the problem is that as far as in India is concerned, because I live in the northern part of the India, as an optometrist, actually we don't understand the concept of binocular visions. So I always use this word even in our part. I'm not sure about the southern part of India. So as far as the ophthalmologic management is concerned, we always use this word vision therapy as exercise, but it is
Right.
not. It is
Yeah.
a lack of basically it is a lack of awareness. We don't know which kind of a vision therapy we recommended, which kind of a management we plan, what is our goal. So that's why we don't know actually. That is you can say that the basic reason why behind that we don't use these kind of therapies. This is lack of it's not a problem of an ophthalmologic side or any kind. As an optometrist, because vision therapy is our basically own concept,
Right,
it's
sir.
our own part. It's not commonly used basically.